Okay. Hi, everyone. My name is Peggy Huang. I'm a fourth-year PhD student in clinical pharmaceutical sciences at Purdue University. Today, I'm going to present my project on physiologically-based pharmacokinetic model in Fontan-Associated liver disease. So the Fontan procedure is used to correct children with a single ventricle congenital heart disease. This surgery creates a conduit that's connect the inferior vena cava directly into the pulmonary arteries, bypassing the heart. It helps correct the reduce workload and then the volume overload on the heart. This surgery significantly improved the survival in these patients. However, it creates a passive circulatory system leading to elevated central venous pressure and reduced cardiac output, as you can see here in the picture, and eventually to end organ damages, specifically the liver. Liver congestion and fibrosis are commonly occurs in this population. We refer to as the Fontan-Associated liver disease. And there are some physiological and demographic changes that are expected in this population that could impact drug pharmacokinetics. In the heart, as we mentioned, it will lead to increased central venous pressure and will also cause reduced cardiac output. These patients often develop renal dysfunction over time. And in the liver, it is unknown whether the expression and activity of the CYP enzyme are different in this population. And if they are different, what is the extent of the changes? And then some data has shown that AST/ALT levels are not directly correlated with the degree of liver congestion from fibrosis. And we also expect that the hepatic blood flow will decrease in this patient population. And the hematocrit will increase if patients are hypoxemia and that the body increase the hematocrit to compensate for the hypoxemia. Decreasing albumin will occur if patients have protein losing enteropathy, which is a losing of the protein leaking into the intestine. And we also expect the absorption to decrease in the small intestine. And also the demographic changes will be identified in this study. We want to look at the weight and height and the BMI and whether the stature of this patient population is different from the general healthy pediatric population. And as time after Fontan increase, they'll have worsened in the symptoms. So the hypothesis of this study is that the physiological and demographic differences that will alter the drug pharmacokinetics. And this will lead to systemic exposure of drugs metabolized by CYP3A and transported by OATP1B1 to be increased. The objective of this study is to identify the physiological and demographic differences in Fontan patients that could impact the drug PK. So the physiological parameters will be identified from the literature, and the demographic parameters will be identified from the literature and the real-world data. We want to use this information to predict the effects of liver congestion and fibrosis on the PK of pravastatin and sildenafil in Fontan population using the PK model. So this study is in collaboration with a clinical study conducted at Children's Mercy, Kansas City Hospital. The goal is to assess the progression of liver congestion and fibrosis over time and their impact on the drug metabolism and transport. It is a longitudinal study conducted over 24 months. They administered sildenafil and pravastatin. And the dosing selection is based on listed here. And they will also assess their MRI-40F to look at the degree of liver congestion from fibrosis. They will also collect the plasma sample, 2 milliliters. And the sildenafil was chosen is because it's primarily metabolized by CYP3A enzyme and is used to assess the CYP3A drug metabolism. Pravastatin is used in this study because it's primarily being uptaked into the liver via OATP1B1 transporters and have a minimum CYP3A metabolism, and is used as a probe substrate to assess OATP1B1 drug transport. And here shows the modeling structure on the left side. On the right side is the modeling workflow. So we'll first verify the adult model in Simcyp using the default drug files for sildenafil and pravastatin. And we'll compare that with the observed data from the literature, and we'll simulate into the healthy pediatric population, and we'll incorporate the physiological and demographic changes that we identified in the previous step here, and to develop a pediatric Fontan population. And we'll use the data from the clinical study to train and validate our model. And today I'm going to talk about adult model verification. Here shows some of the physicochemical properties of pravastatin and the structure. So pravastatin is a lipophilic drug with low bioavailability, and 34% is absorbed in the intestine. So these parameters will be used in the Simcyp to help with our adult model verification. And here we compare to the two observed data from the literature. On the left side is the study conducted by the Huang study. They administered 40 milligram single oral dose. On the right side, they administered 20 milligram single oral dose from the Dan study. And then you can see the gray lines are the 5th and the 95 percentiles. The green line is the simulated plot, and then the dots are the observed data. So the table below shows the predicted versus observed ratio for Cmax and AUC. So you can see here they are all within the twofold range, indicating that the simulation is fitting quite well to the observed data. Sildenafil drug properties are shown here. It is a highly protein-bound drug with 95% of protein binding, and its metabolite is also active. So these parameters will also be used in our adult model verification. And we also compare to two clinical studies from two literature. And then, as you can see here, they both are administered 50 milligram single oral dose. They are age matched to the population from the literature. And the predicted versus observed ratio are also within the twofold range, indicating the data is fitting quite well. The next step is that we want to simulate different dosings in pravastatin and sildenafil, and then simulate into the pediatric healthy population, and then develop the Fontan population in Simcyp. So we expect that as the degree of liver congestion and fibrosis severity increase, it will lead to decreased hepatic metabolism and transport, leading to increased systemic exposure of sildenafil and pravastatin. This model will successfully predict the pravastatin and sildenafil plasma exposure in patients with different degrees of liver congestion and fibrosis, which will help clinicians optimize dosing for the individual based on different fold stages to improve efficacy and minimize toxicity. This model can be applied to other commonly used CYP3A and OATP1B1 substrates in patients with Fontan circulation. And here's my acknowledgement. And thank you for your attention.